said, going on something like that. I had it right. Education. If that covers because the argument for students look at the place. I mean, the university, different thing. It's very expensive for students. And residency.
Good afternoon, everyone. Thank you so much for coming to our Grand Rounds conference. We have our complex case conference today. Our presenters are Anita Rao, PUI2, Fabi D'Ambrosio, PUI3, Dr. Sylvia Robinson from Peds Endocrinology, Dr. Schmidt from Hematology Oncology, and Dr. Shah from Genetics. Thank you.
Okay. Hi, I'm Anita Rao. So our case is a 2-week-old male Hispanic infant who presented to the ED with multiple twitching episodes. So these episodes have been occurring for 1 week. Patient was actually previously seen in the ED when he was 6 days old. And at that time that was the initial presentation, he had 3 total episodes of jerking. And he was diagnosed with benign myoclonic jerks. He was discharged home with no labs done and with just PCP follow-up. So now episodes have become more frequent. They're occurring every 15 to 20 minutes, and they're lasting 2 to 10 seconds at a time. The patient otherwise has a normal activity level. Mom says that he's drinking formula well, about 2 ounces every 2 to 3 hours, no feeding intolerance. So review of systems, he has no fevers. There was no prior trauma of any kind, including head trauma. He has no fussiness or irritability. HENT is completely negative. There's no sweating or color changes with feeding. There's no apnea, no cyanosis, no respiratory distress. He has no vomiting, no signs of reflux, no rashes or bruising. In the ED, his temperature was 37.1, heart rate 133, respiratory rate 44. He's satting 100% on room air. So vitals are stable. He's in no acute distress. He's smiling, alert, and interactive. On HENT exam, frontal bossing was noted. But otherwise, there's no nystagmus, pupils weak around reactive. The rest of the exam was normal, except for the extremities. Bilateral wrist widening was seen. Neurologically, he was completely intact. He has all his primitive reflexes, cranial nerves 2 through 12 are intact, good tone. Patient had 2 witnessed seizure-like episodes in the ED that both lasted about 10 seconds. There was shaking of the left upper extremity, twitching of the left face, shaking of the bilateral lower extremities, and a left-sided gaze. Mom says this is similar to his seizure presentations at home. He was kind of fussy and irritable for about a minute afterwards, but then quickly returned to baseline. So he was loaded with phenobarbital, 20 mg per kg. He was euglycemic, Accu-Check was 95. They got a head CT in the ER that was negative. And a comprehensive metabolic panel was ordered, but it clotted twice. So there are no labs available for the patient. Okay, I'm gonna briefly go over his gestational history. So this baby was born to a 31-year-old G6P3 at 39 plus 2 weeks. He was full-term AGA. Pregnancy course was complicated by consanguinity. Parents are first cousins. All of his prenatal ultrasounds were normal. Mom also had 2 molar pregnancies previously. So in terms of the serologies, GBS was negative, not treated. Only thing was rubella was indeterminate. Otherwise, all serologies were negative. So patient had no hyperbilly in the nursery. TSP 24 hours of life was loaned from the uterus zone. He passed his hearing screen bilaterally and he passed his heart test. He was only noted to have poor feeding. He had a fair suck, was kind of sleepy, but on the day of this discharge, this improved, and he was drinking formula well. So this patient was transferred to the NICU for further care. He was made NPO and he was started on IV fluids for a TFI of 120. He had continued seizure-like activity. He was loaded again with phenobarbital, 15 mg per kg. So these are his initial labs. His ClinChem looks normal. We got liver profile, and albumin is 3. It's otherwise within normal limits. There's no leukocytosis. White cell count is 10.7, no anemia. His CRP is less than 0.5, so there's low concerns for infection. We also got a calcium. His serum calcium was 5.8, so markedly low. Phosphorus 7.1, which is on kind of the higher limit of normal. 25-hydroxy vitamin D was less than 8, so it was pretty much undetected by the lab. Reference range is 20 to 80. PTH was 340, so markedly elevated. We also got a renal ultrasound that was normal. All right. So the patient required 2 IV calcium gluconate infusions to increase his serum calcium from 5.8 to 6.8. Endocrinology was on console. They recommended continuing the calcium gluconate, 300 mg per kg Q6 hours, and also starting calcitriol. Feeds were started on day of life 2 with Similac PM 60/40. This formula has a higher calcium to phosphorus ratio, which is why it was chosen. So the patient was started on maintenance phenobarbital, and neurology recommended getting a spot EEG on day of life 17. This showed multifocal epileptogenic cerebral dysfunction, so it's likely due to the hypocalcemia causing increased cortical irritability. Genetics was also consulted because there was consanguinity in the past medical history. Newborn screen is still pending.
Good afternoon, I'm Fabi D'Ambrosio, one of the PGY3s on Peds. So we have now our differential for hypocalcemia in the newborn. So a brief summary, we have a 2-week-old ceasing newborn with physical exam findings, so frontal bossing, wrist widening, hypocalcemia, hyperphosphatemia, low vitamin D, elevated PTH, and normal renal function. That's kind of the summary of what we have at this point. So hypocalcemia is a very common metabolic finding that we can find in newborns. So let's define it and it's differentiated on term and preterm infants and depending on the weight. So we have a term infant or preterm infant with birth weight more than 1,500 grams. The total calcium, it's less than 8 will be considered hypocalcemia, and ionized calcium will be less than 4.4. Very low birth weight infants, the total calcium can be a little bit lower, and it's considered like less than 7 hypocalcemia, and ionized calcium less than 4. So to classify it, the hypocalcemia we have early and late depending on the day of finding. On our little guy, he had the first twitching episodes on day of life 6. So that would be something to remember. So early would be considered the first 3 days of life, and it can be related to prematurity, IUGR, perinatal stress or asphyxia, infants of diabetic mothers. And the late side, we have hyperphosphatemia, PTH resistance, hypoparathyroidism, vitamin D deficiency, skeletal dysplasia, and most specific osteopetrosis, and phototherapy, blood transfusion, and alkalosis. So how do we approach hypocalcemia in a newborn? First of all, we have to confirm our lab. First, the total calcium level, and as well, if possible, ionized calcium. We verify the serum albumin level, because as we know, if the albumin goes below, decreases for 1 gram, our total calcium can decrease by 0.8 milligrams, but the ionized calcium will be fine. We check for clinical findings that could be seizures, tetanus, muscle spasm, irritability, fussiness, which in our newborn could be presented. And obviously, depending on our suspicion, we have further lab work. So of note, the calcium transfer from mom to baby happens mostly in the 3rd trimester. So after birth, when this transfer stops abruptly, our total calcium in the baby and ionized calcium can drop a little bit to levels of 8 to 9, but these levels are asymptomatic. And this is due to decreased PTH levels in the baby. As the PTH starts to rise and it's more sensitive, and the parathyroid gland becomes more sensitive to the hypocalcemia, there's a slow rise, and by 2 weeks of life, we should see normalized calcium levels. On preterm babies, the hypocalcemia can be a little bit more prolonged, but something that we are checking when we have our preemies in the NICU. So a little bit to continue, and we'll talk a little bit more afterwards. On newborn babies, PTH is low and is poorly responsive to hypocalcemia for the first 2 or 3 days of life, which makes our transient hypocalcemia. Calcitonin is elevated in the newborn and remains high for a couple of days, which also helps on our let's say transient physiologic hypocalcemia. And PTH secretion and calcium homeostasis usually normalizes by 1 to 2 weeks of life in our full term, and 2 to 3 weeks on preterm infants. So this is a very summarized calcium homeostasis. So we have elevated, let me see, how do I press it? Okay. So we have low calcium levels. This will stimulate our PTH production. The PTH will stimulate the release of calcium from the bone, as well as the increased reuptake of calcium from the urine, as well as activate the 1/2 hydroxylase to produce increased absorption of calcium in the intestines. All of this will increase blood calcium, and then we have normalized calcium level or elevated calcium levels. As this happens, then we have the opposite effect. So our calcium rises. We have thyroid gland release calcitonin from the C cells, and this calcitonin will stimulate calcium deposition in the bones and reduce the calcium uptake from the kidneys. Calcium will fall, and our cycle starts again. So we're back to our patient. We have this clinical and chemical findings. So let's talk about our differential. So first of all, we said that it's day of life 6, so we can rule out the early causes of hypocalcemia. So we are done with, we just have late. Of the late, let's first do the basic and the most obvious. The patient has not received phototherapy, has not had blood transfusion, has not known alkalosis, so we can rule that out. The patient with hyperphosphatemia, he is on cow-based formula. However, we don't know any extra phosphorus supplementation that we know, and there's no renal dysfunction. So we can rule that one out. Then we have PTH resistance, which is known as pseudohypoparathyroidism. We can see hypocalcemia, hyperphosphatemia with elevated PTH. So let's think about that. Then we have our hypoparathyroidism. Even though that this is presented with low PTH, we have other clinical findings. So at this point, let's just humor that one. As vitamin D deficiency, we have a low 25-hydroxy vitamin D. We have hypocalcemia. We have elevated phosphorus, but with vitamin D deficiency, we actually could have normal or low levels of phosphorus. But we do have an elevated PTH, and he has clinical findings of wrist writing, which is something that we see in vitamin D deficiency. So let's talk about that one. And then there are multiple skeletal dysplasias, but the only one that we, at this point and through the research that we did, the only one that knows to cause hypocalcemia is osteopetrosis. And you can also see wrist widening, you can also see frontal bossing. So let's talk about that one as well. So hypoparathyroidism, we see hypocalcemia, hyperphosphatemia with normal renal function. It can be due to impaired synthesis or secretion of PTH. The most common syndromes that we can see, and it's DiGeorge and Catch-22, which is a chromosome deletion of 22q11. And the clinical findings that we have is parathyroid hyplasia, hypoplasia, cardiac defects, abnormal facies, thymic hypoplasia, and cleft palate. At this point, our patient, the only thing that we could see would be the hypocalcemia and the abnormal fascia. However, we do know that the patient is producing PTH. So there's also a kind of secondary, which could be due to maternal hyperparathyroidism, which sometimes is mom is asymptomatic and she doesn't know, or maternal hypercalcemia, which will downregulate the baby's PTH. So we have also pseudohypoparathyroidism, which we see hypocalcemia, hyperphosphatemia with elevated PTH, which means is that the target organs, which is skin and bones, are unresponsive to PTH. And this is tested when we give an exogenous PTH administration and there's diminished response of the cyclic AMP. The most common type is 1A, and it's also known as Albright hereditary osteodystrophy, and it's autosomal dominant, and usually this kind is maternally transmitted defect. The clinical findings are round facies, short stature, short fourth metacarpal bones, obesity, and developmental delay. There's also what's called pseudo-hypoparathyroidism, which is the defect is transmitted through dad's defect, and they have phenotypically look like AHO. However, their calcium is completely normal. This is kind of the findings. So if we see, the fourth finger looks pretty short, and it's just due to the shortening of the bone. And you're gonna have a dimple. So you're gonna see knuckle, and then a dimple. So that's usually kind of a finding that we see. Then we have vitamin D deficiency, which is low 25-hydroxy vitamin D. Causes that we can describe is deficient intake, no sun exposure, and disturbance in the metabolism. When neonates are exclusively breastfed and without any supplementation of vitamin D, we can see this. However, a patient is formula fed, and we assume that he was taking his vitamin D. Maternal vitamin D deficiency is a major factor of neonatal hypocalcemia. Also, we can see because vitamin D, 25-hydroxy and 125 can actually go through the placenta to the baby from mom to baby. So if mom is really with hypovitamin D, baby can have vitamin D. Also problems with the metabolism, hepatic dysfunction or renal dysfunction, which at this point we know that the baby does not have. And the clinical findings are parietal frontal bossing, widening of the wrist, seizures, bowing of the femur and tibia. So this is kind of what we can find. We can see the wrist widening here. And obviously this is a very severe form of vitamin D where you can see all of the findings, but this is a very, very new baby. And then we have infantile osteopetrosis, which is a rare congenital disorder related with osteoclast dysfunction. So there's abnormal remodeling of the bone becomes brittle and is prone to fractures. There is sclerosis and remodeling of the skull that can lead to compression of the cranial nerve too, and that can lead to blindness. And it's a radiographic diagnosis. There's secondary risk of anemia and even pancytopenia secondary to bone marrow involvement, and we can see in hypocalcemia at any stage of life. And then we can see this is a normal bone, looks like a little sponge, and then this one the holes are a little bit bigger, so not so pretty. So going back to our differential, so we have this 4. At this point, we know that PTH is elevated, so we can rule out hypothyroidism. The other 3, we were still thinking about those, mostly because the patient does have vitamin D deficiency, and he does have the kind of chemical findings for the other ones. So at this point in our research and team, we're with those diagnoses.
So just to give you some more background on the patient, mother's previous child died at the age of 4 from osteopetrosis. This was diagnosed at 3 months of age by radiographs. And so it was a pretty progressive form. The patient did have 25-hydroxy vitamin D and calcium levels done when he was 24 hours old due to this family history. So the 25-hydroxy vitamin D was 21, calcium was 6.4. They were both within the reference ranges for the lab, but kind of low. So due to the family history, a skeletal survey and neurology follow-up were recommended. So the skeletal survey was done in the ER when the patient presented the second time. and it showed irregular and widened metaphyseal epiphyseal plates in the distal long bones. So in view of the family history, osteopetrosis is high on the list of potential differentials, but it's not supported emphatically. So this is the patient's skeletal survey in the ER, and I have a normal example on the right side. It was easy to see. But it's more common in the femurs that you can see there's actually very little cortical medullary differentiation. So the entire bone just looks white. Usually you would see hypolucency in the middle, which kind of indicates neurospace. So in a normal example, you would see this kind of hypolucency in the middle, and our patient did not have it. It was just completely white bone. So there is some type of osteosclerosis happening. They also noted an elongated metaphyseal epiphyseal region that's due to the marrow involvement, so the bone extends out this way. So it kind of looks like a dumbbell compared to a normal bone. So in the NICU, the patient received a total of 6 infusions of calcium gluconate. As calcium levels began to normalize, we saw that his phosphorus started to decline, even to as low as less than 1. So the calcium and phosphorus levels were very closely checked. Patient was actually discharged on both PO calcium carbonate and Nutrifos. So just to normalize both the calcium and the phosphorus levels. His levels were stable at the time of NICU discharge. EEG was repeated on day of life 19, and it showed continued multifocal spikes, but it was improved from the previous one. MRI brain was done on day of life 20, and it was largely unremarkable. They showed possible delayed myelination of the posterior limbs of the internal capsule, but otherwise no anatomical abnormality that would be a cause for the seizures. The phenobarbital was slowly weaned. Patient had no further clinical seizure activity, and the medication was discontinued on day of life 35. So the patient's skeletal survey was analyzed by radiologists at Shriners, and they considered it highly suspicious for osteopetrosis. The patient also had a SNP microarray, which is still pending. We did a CT scan in the ER, and it showed no evidence of foramina narrowing, which you would see in more prolonged osteopetrosis. HLA typing labs were done on both the patient, the mother, the father, and the sister for a potential bone marrow transplant. The patient was discharged from the NICU at 5 weeks of life. He had a 21-day stay. And he was seen in follow-up at 6 weeks of life. And at that time, the patient was noted to no longer be tracking objects. He had a disconjugate gaze and appeared to be sundowning, meaning his eyes were turning downward. On exam in the neurologist, his pupils were 2 to 3 millimeters and non-reactive to light. And he appeared to have a disconjugate gaze. They did do a CT of the orbits, which was normal, but clinically he appears to not be able to see. At 3 months of life, the patient received a bone marrow transplant at the University of Chicago, which we'll discuss more in later slides.
Hi everybody, I'm Sylvia. I'm the first year endo fellow. I'm just going to talk a little bit about osteopetrosis. So it's a group of heterogeneous heritable diseases that all have the unifying feature of having a high bone mass. It was previously grouped into 3 types: infantile, adult, and intermediate onset, but we're now moving more towards categorization based on inheritance pattern and specific mutation. The incidence is 1 in every 300,000 births in the autosomal recessive form and 1 in every 20,000 of the autosomal dominant form. Increased bone mass can either be due to decreased bone absorption or increased bone deposition. Traditionally, we consider osteopetrosis as a disorder of osteoclasts, whether there's either an issue with the number of osteoclasts or their function. So this is just kind of an overall summary and table of the different types of osteopetrosis. It's not really exhaustive, but it's kind of more of the common ones. But also keep in mind that 30% of causes have no known genetic mutations associated with it. So as you can see, mode of inheritance in the case, it's not working. In some cases, like with the CLCN7 gene, can both, it's usually autosomal recessive, but can cause different clinical presentations depending on whether it's homozygous or heterozygous. All of these tend to have the skeletal manifestations, which include increased bone density, pathological fractures due to the osteoclast not being able to remodel bone that may have been damaged, or even get rid of the calcified cartilage that later would become bone. There are other manifestations depending on the mutation that is causing the disease, which I'll get into a little bit later. As you can see here with onset and severity, it can vary from perinatal onset all the way to late childhood and adolescence. Severity also varies depending on the type of mutation, but most cases are moderate to severe unless it's kind of in the autosomal dominant kind of late childhood adult category. But before we get into some of the specifics for each mutation, I just want to take a quick second to talk about normal bone physiology and calcium homeostasis, which Fadbi kind of went over for us, so it'll just be really brief. But these two systems work in conjunction to maintain calcium homeostasis and also to keep bones healthy. So here we see that the osteoclast kind of lay down the new bone, it becomes quiescent, this new bone, and then there's some sort of activation, either stress on the bones, a microfracture, or even PTH that causes the lining cells to retract and the underlying membrane to be exposed, and that is kind of the signal for the osteoclast to move in and fuse and become activated. Once they're there, you get digestion of the underlying bone. And after that's done, the osteoblasts move into the resorption cavity and form new bone, and it starts all over again. So like I said before, the PTH is sometimes instrumental in kind of getting these underlying cells to retract, so that the PTH is actually involved in activating the osteoclast so that they can then resorb the bone and help remodel it to get it nice and healthy. And now we're going to get into a little bit of the osteopetrosis pathophysiology. I looked at kind of the most common mutations. This here is just a figure of an osteoclast. This is the ruffled border where resorption takes place. So starting kind of from the outside and working our way in, the carbonic anhydrase enzyme basically is responsible for taking water and bicarb and changing it into protons and bicarb here, so that these protons can then be transferred and make the environment acidic. So any mutation in here that prevents the production of protons means that we can't acidify the environment and therefore can't resorb the bone. Here we have the TC1RG1 pump, that is a proton pump that transfers the protons from the osteoclast into the lacuna. So again, even if we can make the protons, if we can't transport them into the area that needs to be resorbed, then we're not going to break down bone. Next, we have this CLCN7, which is basically a chloride channel. It helps to maintain the charge because we have the positive charge protons going in here, along with the chloride to keep it balanced, and it also is helpful in breaking down the calcium and phos. The chloride is helpful in breaking down that complex. So without that, again, you won't have resorption of the bone. There's also here we see this rank receptor, and this is responsible for helping to help the osteoclast mature. If this is not present or rank ligand is present, then you won't see any osteoclasts and therefore won't have any resorption. These down here I'm not going to focus on too much because it's most of the osteoblasts. It's increase in bone mass due to osteoblast overproduction as opposed to osteoclast, and so not going to focus on this, but this is just here to show you some other causes of high bone mass. So this is also a little bit kind of a repeat of what Anita said. Up top, if you can see, this is osteopetrotic bone. It's really homogeneous and you can't see a bone marrow cavity. This second one is about 2 years after a stem cell transplant has been done, and you can see the bone marrow cavity there. This first picture is before a bone marrow transplant. You can see there's not really a lot of hematopoiesis going on in these areas where there should be, and there's a lot of calcified cartilage. After the bone marrow transplant, you see here hematopoiesis kind of is more prevalent, and there's less kind of calcified cartilage, showing you the difference that a bone marrow transplant can make if the patient is of the right type and right mutation to proceed with it. So going back to our patients' labs, initially we came in, we said the calcium and the phos were low, the PTH was high, and the vitamin D was low. So why would this be the case? In osteopetrosis, we tend to think that they have high bone mass and therefore should have high calcium stores. And they do overall. But since the osteoclasts don't work, then they don't have access to that calcium that's present in the bones. And so we see that the vitamin D level was also low at the time. So what we were thinking is that the infant was not able to take in enough calcium and vitamin D to keep their levels normal. And this is kind of what caused the low calcium, because if they're able to take in enough of these things, then you won't necessarily see this happen in osteopetrosis. But it can if they're not able to take everything in. And this just shows kind of over the course of treatment, which I'll talk about a little bit in a minute. PTH came down nicely. Vitamin D came up with supplementation, and the activated vitamin D level on the higher side. So basically for osteopetrosis, endocrinology, our management is typically symptomatic. So in our patient's case, he had osteopetrotic rickets. And so first we have to treat the rickets. He had low vitamin D, so we started him first on ergocalciferol, which is a 25-OH vitamin D, where generally in osteopetrosis we would give activated vitamin D, the calcitriol, because we just give the activated vitamin D calcitriol and then also calcium supplementation. Sometimes steroids are also used. One, it kind of helps with the underlying hematologic issues that they may have, and two, it also has been shown to increase transiently bone resorption. And then you consider hematologic stem cell transplant depending on the clinical presentation and severity. So just going back to this chart of the different types, I didn't go through all of them, but just the most common ones. This classic form of autosomal recessive caused about 65% of autorecessive osteopetrosis, and the other 15% is caused by the CLCN7 gene. So treatment, as you can see here, is usually supportive. There are certain ones that may benefit from stem cell transplants and others that either we don't have information to show that bone marrow transplant would be helpful, or that may not help at all. And sometimes it might have to do with whether the mutation is intrinsic or extrinsic to the osteoclast. So those that are intrinsic to the osteoclast tend to benefit from stem cell transplant, whereas the others don't. Prognosis, typically poor and can sometimes be fatal in infancy because of some of the hematologic issues leading to sepsis and death in that instance. But others are variable, and if you have the autosomal dominant form, there's typically a normal life expectancy.
I'm actually just Nitty today, a little bit taller, because she actually has taken care of this patient, our fellow, and made these slides, but she's doing her in-service. Oops, sorry. So we are just focusing on the hematologic aspects of this and not going over the details that Fabian, Sylvia, and Anita did. But basically, in this condition, there's effacement of hematopoietic tissue by this fibrous tissue that can cause severe pancytopenia, and I think you could appreciate that from the slides of the bone marrow. You can see there just isn't enough hematopoietic cells being formed. And then that can lead to anemia, thrombocytopenia, and neutropenia, and that can lead to life-threatening or life-ending infection or bleeding or symptomatic anemia. So there can be hematologic impairment in the first year of life, and it's relatively common, but if its onset is within 3 months, it's an indication of very poor outcome. And neutropenia, of course, can make the patient more susceptible to opportunistic infections, but prophylaxis like for pneumocystis is not generally recommended. So this patient actually had some mild anemia. This is just in the first 3 months of life, and some mild leukopenia, but not actually neutropenia. So the options for this patient, as Sylvia just said, was either supportive care, which was done for the older brother, who, by the way, had deteriorating neurologic status. He had vision loss, change in his facial appearance, multiple nerve impingement leading to pain, restriction in his movement, and he died at the age of 4 years due to respiratory failure. The alternative was hematopoietic stem cell transplant. Untreated, and I know that Dr. Schott is going to talk about this because we had some limitations in this patient, but in general for the autosomal recessive types, you could expect a mortality rate to mirror what happened with his brother, in that 2/3 of the patients might die by 6 years of age. And it's generally due to this bone marrow failure problem. The osteoclasts are hematopoietically derived, and so if you have an intrinsic defect, as Sylvia just said, then you can actually reestablish this by an allogeneic graft. And then after that, there will be differentiation of functional osteoclasts, and then that can lead to bony remodeling, that can lead to reversal of the pancytopenia, and the patient can do well. So the goal of hematopoietic stem cell transplant in our patient would be to prolong survival, maximize his neurologic development, and in other patients prevent vision loss. But unfortunately in our patient, vision loss had occurred by 3 months of age and wouldn't be expected to be improved. So the next step is, of course, donor identification. As they said, the HLA testing was done, but unfortunately his only fully matched sibling was not a match. So the options would be either cord blood, stem cells from an unrelated donor, or peripheral blood from an unrelated donor that were matched, or haploidentical parent or sibling. So just looking at the complications of stem cell transplant, because this was a possibility for this patient, but certainly not a requirement, and if family had decided to use just supportive care, we certainly would have supported them in that decision. So in the short term, we have to worry about graft rejection, infection, bleeding, acute graft versus host disease, veno-occlusive disease of the liver, pneumonitis, and then any immediate side effects from the preparatory regimen, whatever was decided. And then long term, we have to worry about late graft failure, chronic graft versus host disease, which can be pulmonary, skin, liver, basically any organ, infection. They can have altered growth and development from the preparatory regimen, endocrine dysfunction, sexual dysfunction because of the preparatory regimen, the drugs that we use, like let's say busulfan and melphalan, and then depending on how long they need the immunosuppression, short if they don't have graft versus host disease, but long if they do, then you can have complications depending on which immunosuppressive regimen. If you use steroids, you have to worry about aseptic necrosis of the bone. If you're using other immunosuppression, infection. And then the risk of second malignancy. So there was a relatively recent 2015 international study of 193 patients who did undergo stem cell transplant for osteopetrosis. The majority of them were young. 133 of these were transplanted in the first year of life, so this was a good comparison to our patient. If they had an HLA matched sibling, which unfortunately in our patient we didn't have that, there was a 62% survival at 5 and 10 years. So that's in comparison to the 70% expected death rate by 6 years of life. So this did show significant prolongation in survival. And even with alternative donors, which had to be used in our patient, there was about a 40% survival at 5 and at 10 years. So that was encouraging, but not as optimistic as if this patient had had a matched donor. The most common adverse event, if the patient survived, was learning disability and visual impairment. But graft failure was the most common cause of death. For the matched siblings, about half of the patients had graft failure as the cause of death, and for the alternative donors, about 40% had graft failure. So graft failure can either be get graft rejection, like the cells never even engraft and are established, or they engraft and then gradually are lost. So what we do is we monitor for chimerism, the donor stem cells. You find a polymorphism that is different between the donor and the recipient, and then you track that, okay? So if it's different sex, then it's pretty easy to track, but I think this donor was male, as I understand it. So full donor chimerism implies that all of the cells being made are from the donor. That would be 100%, and then mixed would be the balance, like 80-20, 70-30. So the feedback that we've gotten from the University of Chicago is that the baby was transplanted on September 29th, 2016. So I believe that the date of birth was in May? June 2nd. Okay, so this baby was transplanted by 4 months of age and with a fully matched unrelated donor. And there was successful engraftment, so that's good, by October 22nd, so really within even 3 weeks of infusion of those stem cells. The patient was off immunosuppression by 60 days of age and is now, at our last communication, 119 days. The chimerism studies to us look a little bit worrisome because donor DNA was 77% on December 8th, 49% on January 9th, and 32% on January 23rd. Now, you don't need 100% engraftment, and some people can actually just smolder along with some combination of patient's own cells and the donor cells. And in fact, a European group showed that if you have even just 10 to 20% donor DNA, then that can prevent the recurrence of the phenotype of osteopetrosis. So the 32% is worrisome, but if it's stabilized even a little bit lower, the baby could still do well with that.